Thank you. I have good news and I have bad news. The bad news is I'm not an expert on this, except that we use it a lot in the unit. We use CPAP and we use NIPPV, but research-wise, I've done none in this area. Nevertheless, the good news is that I'm unbiased, so I don't have any bias, and I had a fresh look at the literature. And they wanted me to talk about the pitfalls of ventilator and devices that give CPAP and NIPPV. And there you go already. What are pitfalls? And what do you do if you're not an expert and you have to talk about pitfalls? You know, you go to your colleagues and you ask them, what do you think is pitfall? We have 10 neonatologists in our unit, and 3 of them said, well, pitfalls, don't know. I don't know any pitfalls of giving CPAP and NIPPV, so that didn't help very much. 5 of them said, well, what I find difficult is when I read the literature, what do I have to believe about the advantages and the disadvantages of giving CPAP by a device or a ventilator? And 7 out of 10 said also, what we noticed with the infant flow driver or with the ventilator with a variable flow is that sometimes you have to give rather high flows to reach the CPAP pressure. And even then, if you give a high flow and you say to the nurses on the high care unit where we have infant flow drivers, I want to give a PEEP level of 7. And the next day you come back and they report you, well, we tried to give 7, but we only reached 5. It's very often that the flow, or I don't know, it's about 11, max is 11 liters per minute on the inflow flow driver. It's very often that they don't reach the CPAP pressure. So that was a pitfall for my colleagues. And well, 7 also mentioned complications, like the distended abdomen, the pneumothorax, and the nasal trauma. But those are complications, those are not pitfalls. So I decided not to talk about that. And I asked them, which one do you prefer? Because we use the AVIA, CPAP and NIPPV, and we use inflow drivers in the high care unit. Which one do you prefer? And they all preferred the ventilator device. That is, of course, a bit biased, but I was a bit surprised by it. Because before we introduced AVIA, we had the infant star, and we had the infant flow drivers, and the nurses and doctors hated the infant flow driver. And then I came with the AVIA, and I needed short binasal prongs, and I introduced the Hudson prongs. They hated the Hudson prongs, and then they loved the infant flow driver because it's much easier to apply. So now they're very used to infant flow drivers, and they don't want to throw it out of the window. Let's first talk about what CPAP actually does. Well, it mimics expiratory braking maneuver. This is what infants do at birth and also later on. On the left side, you see a preterm infant of 28 weeks, and still don't have a pointer, have you? Okay. So I'm going to stand like this. It's no battery. It is out of the battery. I thought it's empty, but anyway, good. Yeah. So this is the mask pressure. CPAP is given. This is the flow, inspiration, and then holds it in expiration. So inside of the lung, outside of the lung. And this is the volume going in and out. What the baby does is that it takes a deep inspiration, then closes the vocal cords, contracts his abdominal muscles, and holds it. Lets a little bit of air out here and there, but holds it completely, and then does an expiration, and then immediately followed by an inspiration. So this is a way of the infant to preserve his lung volume. Not only the breath hold, but also immediate inspiration, so no post-expiratory pause, just to prevent that too much air is coming out. This is a way how he defends his lung volume. And another way to do it is doing grunting. It's exactly the same mechanism, except that they take a deep inspiration and then they almost close the vocal cords, but they increase the interthoracic pressures by contracting the abdominal muscles, and it produces sound. That's the grunt. That's a low frequency noise signal, but it's also a way to slow down the expiratory flow wave. It's just a way how they try to preserve the lung volume. So when they are grunting, it means they're working hard to maintain their FRC. And actually crying is the same thing, but then it's a high frequency noise signal. So this is what CPAP does. So if the infant is working hard and it's grunting, you give CPAP. Yeah. So what does it do? It mimics grunting. The effect is that it reduces the grunting, and some units say, for example, the $100 million question is how much CPAP you should give. They use the grunt. If the grunt disappears, that's the level of CPAP you use. It reduces to be tachypneic also. They allow themselves to have a post-expiratory pulse again, and increases FRC, and because you have a more uniform lung aeration, more FRC, it decreases the ventilation perfusion mismatch. Not only does that, it also splints the upper airways. By pressurizing the airways, the airways the preterms have very little collagen and have tendency to collapse, and you splint them by the positive airway pressure, and so you have less apneas. And also splints the chest. The chest is flexible, and that's why you get very often paradoxal breathing. This is the expensive word for it, but you get less paradoxal breathing. And it also said it stimulates surfactant production, but I think what they mean is that because the baby is still spontaneous ventilating, and that stimulates the surfactant production. Is that correct, Kaisha? Okay. So the CPAP effects is that it improves oxygenation and it improves gas exchange and decrease the amounts of apneas, the obstructive and the central ones. You have a better compliance, and it will reduce the work of breathing. They have to do less effort to get air in and out. So pitfall 1, there is a turning point in CPAP level. Hang on. That's better. So if you have less surfactant, because surfactant prevents, it decreases the surface tension and decreases the lung recoil, the tendency of the lung to collapse, the alveoli to collapse again. If you have less surfactant, you need to give more PEEP. So you do that by grunting, or if the infant can do it, you give it by the machine, the CPAP. And that's good, but you reach a certain level that you give too much PEEP, and then you compress the capillary. And when you compress the capillary, then you get a ventilation perfusion mismatch. So there is a turning point. And then the big question is, where is the turning point? That is even individual per patient. We don't know. This is the animal experiment that's been done by Kelly Crossley. Its PEEP is given, and she has shown by the pulmonary blood flow, fetal and after birth, it increases with giving PEEP because you get more aeration of the lung, and it stimulates the pulmonary blood flow. But above 8, it decreases pulmonary blood flow. So there is a turning point. I'm not saying that 8 centimeters of water is in every infant a turning point, but it depends if you give it for apneas, you have to give lower CPAP level for healthy lungs than in lungs that are less compliant. The CPAP devices. There are different ways to divide them. This is the way I did it. The ventilator that can give CPAP and the CPAP devices. And the ventilator can divide by giving constant flow, and that's how it works with flow opposition. It's a valve control. That's the old baby log, and the infant star does that. So it's a constant flow. Even if the baby requires more flow by inspiration, then you get some flow starvation, so that's a disadvantage. And also if you breathe out, you breathe against the flow, and you get an increased work of breathing. theoretically. Variable flow is that it responds to the demand, so the valves are server controlled, and that's what our VIA does. In the VN500, that is the baby log or not? The VN500, and the Servo-I. These are examples. Then the CPAP device, can you divide between constant flow and variable flow? Constant flow is the conventional way. I don't think anyone else, this has been abandoned. Most of you use or CPAP, bubble CPAP, or the fluidic flip. That's the InfraFlow Drive, Medijet, Arabella. And has different mechanisms, the liquid seal and the fluidic flip. We'll come back to that. So these are the options you have. Did I forget any device that you use? The Loni Plus, that's a ventilator. And has it variable flow? It has fluidic technology, so, oh, okay, sorry.
And the Stephanie.
The Stephanie? Okay, these were just examples. There are many ventilators and there are much more CPAP devices. The funny thing is because I have these examples from reviews, and the Stephanie is never mentioned, and also the Leoni Plus never mentioned, so there's work to do for you guys. Pitfall 2, that's what my colleagues mentioned, how to interpret the literature. Most of the studies have been performed with small numbers. And these are the studies that have been performed with the ventilator versus the InfraFlow driver. And these have shown positive effects to the InfraFlow driver. Less CPAP fluctuations, fewer days of oxygen, shorter duration of CPAP, and lower work of breathing. Again, these are small trials except this one. Also, versus bubble, ventilator versus bubble are small trials except the Tagawa one, and has shown that the bubble CPAP goes less intubations. So if you look at the overview, you would say, well, InfraFlow dive is better than a ventilator, and the bubble CPAP is better than the ventilator. The problem is that these studies, if you read them carefully, there are different methods, different patients, different outcomes, different units. There are all kind of variables that will influence the results, so it's very difficult to interpret and to say what's really true. Peter Davis and De Paoli tried to do it with the Cochrane Review in 2008. I tried to find an update, but I'm not sure there's no update. They have given up, I think. They tried to do a meta-analysis, well they did, and to see which device is better. And the result was that for the pressure generation, so the devices, it was no way they could tell which one was better because of the different designs of the included studies. They could tell us that the short binasal prong is more effective, because this is not the subject of my talk. So the short binasal prong gives less resistance than a long or a nasopharyngeal tube. So still there has to be determined which one is the best device. The other thing what I realized when I was reading the literature is that you read all the studies about the ventilators, but these are the ventilators with constant flow. And now all these modern ventilators have variable flow to give CPAP. I give them some examples, a VIA and VN500. And Jacqui did a study, and he compared a variable flow ventilator with the bubble CPAP, and then he see no difference in failure of CPAP. So apparently it makes a difference if you use a constant flow ventilator or a variable flow ventilator, but then he mostly included more less preterm infants that had more wet lung than RDS. Then if you compare the InfraFlow driver versus the bubble CPAP, there is getting into confusion. One said it's better, the bubble is better than the InfraFlow drive, and the one says the InfraFlow drive is better than the bubble, or they have no differences. And there are no meta-analysis. And it still has to determine which one you have to use. Pitfall 3. Does it work as they say it works? And again, I'm not an expert, but I was getting intrigued about the infant flow driver, how it worked, because this mechanism is really already used years for airplanes. This is how airplanes fly, the Bernoulli effect and the Coanda phenomenon. I never realized that until I was reading the literature about the infant flow driver. So what does it do? It gives a jet of flow, and because it's the jet of flow, so it's a small entrance, the flow is increased. And because the flow is increased and the Bernoulli, the equal of energy, how do you say it? The energy has to be equal. If the flow is increased, the pressure decreases, and then it reaches the nozzle, so where the patient nose is, and then you have a large area, and then the flow decreases, and then the pressure increases, because it has to be equal. And not only that, when the patient takes an inspiration, this is the expiratory valve, so this is the expiration tube, is open to air. He's allowed to pull more flow, more air in than what the flow is given. So it will give you a more stable CPAP pressure. And during expiration, and that's the Coanda effect, the fluidic flip, that's what you observe if you pour tea in a cup, and there's always some drops coming from out of the duct. What's that? From the tip of the, yeah. So the dripping, that's the Coanda effect, because it has the tendency, the particles that goes beneath the surface, it's slowed down, has the tendency to follow the surface. This is how air conditioning works. This is how airplanes work. They used it, this was a mechanical engineer or a student from Cambridge or Oxford, I forgot, who invented the inflow flow driver, and he won a prize with it, and then of course there's a company who bought his device or the idea, and they become very rich with it. But it's very old. This is only what I'm trying to say. And the fluidic flip is so that during expiration there's a pressure increase, and due to the pressure increase here, immediately the angle of this, immediately you get a flip of the inspiratory flow. So the patient doesn't have to breathe against the flow, and it really helps the patient to exhale. So they call it an active expiration, which I think is a misnomer. But so it gives you stable CPAP pressure, and it should give you less work of breathing. So this is how they tell you it works, and it really works on the bench tests. But then, if you look also, this is a bench test. Angela Cripps and Martha Wald did this, all kinds of CPAP devices. And these are the devices that have the fluidic flip or the jet flow. And you see that there's less resistance in the infant flow driver. And the funny thing is they used also the MediJet without a sound absorber. Because the problem with the infant flow driver is not a problem with noise, it makes a lot of noise. So they invented a sound absorber. And they didn't test it on the infant flow without the MediJet. You can see if you use a sound absorber on the expiratory valve, tube, it will increase your expiratory resistance. But anyway, so it showed that it has less expiratory resistance in a bench test. Then in infants, Courtney did this, the work of breathing, it's often quoted. And she compared constant flow with variable flow. And this is the variable flow work of breathing, and it's the constant flow. You can see there's a difference. There's less work of breathing if you use the variable flow, and she used the infant flow driver. But if you read the methods closely, or more carefully, they say, when necessary, the infant mouth was closed gently during data collection to stop any air leak, and data with air leak at the mouth were not used. So this only tells you that the fluidic flip or the less work of breathing only works when there is no leak. And I don't know about you, but I think there's almost always leak because the babies breathe out to their mouth, even if you use a mouth trap. And that's been shown in studies, even if a mouth trap is used, there's still leak. So we're not sure if it works, you get less work of breathing if there is a leak. And what supports this is a study that has been done by Colin Morley. He measured the pharyngeal pressure, so he put a catheter in the nostrils, and he was interested, okay, this is the number on the device we want to give, but what are we actually giving in the nasopharynx? And they observed that the pharyngeal pressure was much less, as we expected, than what the set CPAP level was. And you can see that closed it's higher than passive, so when the mouth is open. You even have a very low CPAP pressure. But if you have the mouth closed, so you reach an average of 5 centimeter water instead of the set of 8. And they never observed an increase of CPAP pressure during expiration. Because if the baby would breathe out through the nose, if the mouth is closed, you should see an increase of CPAP pressure. You should see an increase in flow. And they didn't observe it. So that made them conclude that babies are unlikely to expire through the CPAP device. They expire through the mouth. And it's the same thing what I observe if I do recordings in the delivery room and there's a nasal tube used, and you close the nostril and the mouth, and still you get air, you get flow in, but you don't see any flow coming out because you miss it. It's going through out of the mouth. So we're not sure if the fluidic flip works. It still has to be shown that it really works in the patients in the clinical setting. The IVIA, which we use, well, as already said, is servo controlled. There's a leak compensation bioflow until 50 liters per minute. You can monitor. The problem is you do the pressure monitoring in the device, so there is some delay and a reduced responsiveness. And there's a max of 10 centimeters of water. They will give you an alarm when there is disconnection. Sounds good. That's what I always thought. But when you close up, I made a recording of an infant. This is just at random infant that was on CPAP in the unit. So the set is 8. It receives 7. And you see there's a fast response on the flow. But even that, the maximum flow setting is already reached. And you see the CPAP pressure just decreases. You see it already decreases here, and then the number comes later. So this is also not ideal, but this is real life. This is what happens. Oh. Bubble CPAP. They tell us that the advantage of bubble CPAP is because of the bubbling, you get oscillations. And these pressure oscillations is beneficial for gas exchange. So you need to have the bubble. If you have bubbling, you have the CPAP pressure reached. If you have leak and there's no bubbling, you also don't reach the CPAP pressure. So is it true that the pressure oscillations are beneficial for gas exchange? Well, Courtney asked herself, these bubbling we observe, do they reach the patients? And they did a respiratory trace, rib bands, and they showed that this is the bubble CPAP, and this the ventilated CPAP, and these are the oscillations, and these are the oscillations measured by the respiratory trace. Oh, hang on, sorry, but these are the oscillations by the respiratory trace, and you see there's no difference in oscillations. So whatever the bubbling is there is not really equal to the bubbling in the lung. We can't show it. NIPPV as NIPPV. What does it do? Well, we actually don't know that well. We're just starting to understand, or they start to understand what was actually happening. NIPPV, so just non-invasive ventilation, synchronized or not. It gives recruitment of ELI with pressure change, higher tidal volumes and minute volume, chest wall stabilization, less work of breathing. There's no decrease in inflammatory response, and it reduces apneas. This is just what you read in reviews. You have different devices, and I'm not going to ask you again if I forget any devices, but examples of the ventilator is that the baby log, the new baby log will give you variable flow. Before that was constant flow. Synchronized, the AVIA, and another example is CPAP, but that is not really NIPPV, that's BiPAP. It gives two different CPAP pressures. And you can use the inflow driver for BiPAP and NIPPV. If you read the literature, it's getting confusing. The red ones has shown no differences. And I just want to point out, again, these are small studies, but these are the larger ones. Kugelman showed that NIPPV gives less intubation for RDS, but Meneses 200 infant, there's no difference in intubation for RDS. Then Ramadatan showed NIPPV, there's less intubations. Again, different methods, different way to do it. There are some meta-analysis. In 2012, 3 cryos were included, less intubation for RDS. So I'm talking about NIPPV, not synchronized. 2 trials reduces apnea, 3 trials extubation reduces extubation. So it has some advantages. It can help. If you look at BiPAP, small studies, no difference. BiPAP gives better cast exchange. BiPAP has shorter support, oxygen in the hospital stay. And again, BiPAP is not the same as NIPPV. BiPAP is long inspiratory time, 0.5 to 1 seconds, so what's commonly used, with low cycling rates and less than 4 centimeters of pressure difference. Then as NIPPV looks beneficial, less extubation failure, less work of breathing, less BPD, less extubation failure, less apnea, no difference with NIPPV. So it looks like that synchronized NIPPV would be the way to go. Then Kirpalani published a study. The problem is that he put it all together. So all these units were allowed to use BiPAP or SNIPPV, NIPPV, and versus CPAP. And he showed a large study, about almost 500 infants, no difference in BPD of death, the important outcome. So the analysis says there's no long-term benefit. So what should we do? You should read the literature. Well, first again, does it work as they say it works? NIPPV. The real expert about NIPPV and SNIPPV is Louise Owen in the Royal Women's, and she did some studies. And she observed these are infants with a set pressure of 20 centimeters of water, these are 25 centimeters of water, that most of the time they didn't reach the pressure, what was intended. And only 12.5 were pressures above the step pressure because the baby was exhaling during the NIPPV. So it doesn't really reach the pressure as what you set. This is also a study from her where she observed what happened during breathing and during apneas. And during breathing, she had the Graysby capsule and the respiratory trace. She saw no effect of the NIPPV. There's no differences. And during apneas, she observed that only 5% of the inflations, there was chest inflation observed by the respiratory trace. So apparently what we are giving does not reach the lungs, and that's probably because the babies have a glottis, and they close the glottis and they do what they want. Then she did, because some studies have shown that there is a benefit. Maybe the benefit is because you increase the mean airway pressure, you increase the CPAP pressure. And that's why she compared in a small trial with 10 infants, randomized to 30 minutes of NIPPV, and then to high CPAP and then standard CPAP. And then they observed there's no differences between the high-level CPAP and the NIPPV. There was less time with saturation below 80% of high-level CPAP when compared to NIPPV, but then non-synchronized NIPPV, you had fewer and shorter apneas. So apparently, what the message is that what we are doing with NIPPV is increasing the mean airway pressure. So it could be possible that just increasing the CPAP pressure would do the same thing. Then, from Amsterdam, Ante Verkam and Miedema, they were interested in BPAP, and they did EIT, electrical impedance tomography, and also respiratrace. And they showed, they did also a crossover, so they started CPAP, then BPAP level, 20 centimeters above 6 centimeters, and CPAP. And they did observe a small increase in the end expiratory lung volume when measuring with the EIT, but not with the respiratrace. That's correct. Or is it the other way around? It's the other way around. So the respiratrace are the rib bands. That's inductance, and if you give an inflation, then the inductance changes and you can measure it. And the electroimpedance tomography, that is something that Anton has to explain. But two different ways of measuring it, and in one way you measured an increase of inspiratory lung volume, but there, and also a higher tidal volume. So the synchronization, there is a difference if you synchronize it or not. This is what Bengalari did, just to show you that when you do synchronize, it gives you less work of breathing. You see that there's no peak in the positive pressures during synchronized ventilation, while when you're doing NIPPV, sometimes the esophageal pressure increases. So, but when you compare it clinically, no difference in tidal volume, minute volume, and gas exchange. But there was less breathing efforts. That's what he has been showing here, doing synchronized NIPPV. So it looks like if you do NIPPV, you should do it synchronized. Synchronized, you use the Crazy capsule, and it works fine until there's a high breathing rate. Then it doesn't respond that quickly. You see if you have a high respiratory rate of 72, 40, 80, 40, 96, it doesn't respond that quickly. And that's the downside, because the most infants who need it have a high respiratory rate if they have RDS. So the Crazy capsule works fine until you have a high respiratory rate. So, that was my adventure through the literature of CPAP and NIPPV, and I tried to summarize what the pitfalls were. But the first pitfall is the literature. If you only read the abstracts and the conclusions, you might make the wrong conclusion for your unit. You have to read the studies carefully and interpret them. Sounds like an open door, but it's there. And if you read the literature, which device to use, I don't think there's any advice you can give, but I will come to that. And the other pitfalls, the baby have mouth and nostrils, so they can leak. And if it leaks, you don't have a fluidic flip. And if you have leak, you have less CPAP pressure. That's a pitfall. And the other one is with NIPPV, the babies, and also doing CPAP, babies have a glottis and they close and open the glottis when they want. So it's not really the case if you give an inflation doing NIPPV that it also reaches the lungs. Which device to use? Come to that. Should we give NIPPV or just increase in CPAP level? I think more studies have to be done. I think a large trial needs to be done. And if you give NIPPV, probably the way to go is to give synchronized. But which device to use? Well, Colin Morley read an editorial for one of the randomized trials, and this was his conclusion about all the studies, that the conclusion seems to be that it doesn't matter which CPAP device you use. And he considered that as good news, because then you can use the device you're most experienced in, what the nurses find easy to use, and what's the cheapest one. And I think he's right. Thank you.
Excellent. Thank you very much, Ariane. Questions? Comments? I think you left.
It is frequently claimed that different CPAP devices have a different tendency to blow up the abdomen. What's your view on that?
That's a complication, and I decided not to talk about complications. So I can only tell from our own experience is that some babies get a distended abdomen with a certain CPAP pressure, and some babies with the same CPAP pressure don't get a distended abdomen. And it must be that they swallow air, because the pressure of the esophagus is much, the opening pressure of the esophagus is much higher than the CPAP pressures we give. So I think, you ask my opinion, I think because they swallow, and they swallow the large volumes of air into the abdomen. But I don't have find any literature that shows that one device gives more distended abdomen than the other, but have you? Good.
So can I ask you, how many of you use a separate CPAP device? So almost 2/3 at least, I think. And the rest of you use the CPAP from the ventilator. Good. I think we have a question over here. There.
We used to talk of premature patients when we talk about CPAP, but I would like to know what pressure you use when we have a term baby with a typical transitory respiratory distress syndrome for the very first 24 or 48 hours. Not to have, we used to have a lot of pneumothorax at the very beginning of the use, usually when the baby cries, when he is very awake.
So your question is, which CPAP level should I use with babies with wet lung?
Yeah, the pressure, because we talk about higher pressures, but it seems to me, in my experience, 7 or 7 millimeters of pressure in a term baby, it can be a lot.
Well, we don't know what pressures we should give, and I think you should, what I would do is, if there's oxygen need, I would titrate the CPAP pressure based on the oxygen need. I would start with 5 and see how it goes, and go up until 8. We use max of 8. The pneumothoraces is a different story. Yes, they have a lot of pneumothoraces, and CPAP also increases the risk of pneumothoraces, but also ventilation increases the risk of pneumothoraces, and also they can create the pneumothoraces spontaneously by creating very high pressures at birth. So I would start with 5 and titrate up until 8, but that's what I would do. But you can't base on literature or studies to say this is the number we have to use. I think again it's personalized medicine. You have to approach the patient individually and see what he needs. So if he's still grunting and still working hard on CPAP of 5, perhaps you have to give some more. And there's always a risk of pneumothoraces. But also if you give less CPAP pressure in a baby with RDS, also RDS is a risk factor for pneumothoraces.
So in your opinion, Adrian, if this discussion is about devices, is there a difference between devices? How high you would like to go in pressure, in terms of pressure stability, or, I mean, there's...
Based on literature, no.
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 Okay.